G'day, I'm Ben Simon. I'm a paediatric emergency physician, and today I'm going to give this talk on understanding MHPs. For those of you who are attending Optimus Trauma, this will be presented on the day. So this is really just here as an online resource for you to come back to, or if you really like to prepare for a course or want to learn more about MHPs, feel free to watch. So the goals of this particular talk are to understand core components of an MHP. We want to understand the difference between standard and ROTEM or TEG-guided MHPs. And we want to consider the team factors that are very specific to massive hemorrhage protocols, because there's a lot of nuance to this that can be a bit different to some of the tasks we regularly do in emergency. So when are we going to actually activate an MHP? And I think there are a number of guides out there, a number of criteria, like if you're transfusing or expecting to transfuse more than 40 mils per kilo of blood in a trauma. But basically, from what we could get in conversations with blood bank, is that they want to be activated early if we're thinking about it. So the guideline for quick QCH in particular is pretty liberal. It just says if you have critical bleeding or where large volume transfusion is anticipated, they'd rather have you activate it. And I think that's pretty fair. So it's important for you to find out how you activate an MHP in your hospital. And usually that's going to be on your massive hemorrhage algorithm. So it's worth checking your clinical guidelines and reviewing them, because this is a complex task and you don't want to be reading it for the first time when you've got a kid bleeding in front of you. MHP or massive hemorrhage protocols can be a pretty overwhelming and confusing concept, and they certainly were for me. We don't see a lot of trauma in kids, so you can work as a pediatric emergency physician like myself for 10 years and never have to activate one. So this is a really rarely rehearsed skill, and that comes with a lot of challenges. And one of those is just familiarity. And certainly for myself, when I tried looking at massive hemorrhage protocols and looking at adult algorithms, it seemed pretty confusing. But actually, now that I've learned more about it and helped design some massive hemorrhage protocols, it's actually pretty straightforward. So if you look at it, these are the kind of the things that are common for every massive hemorrhage protocol, no matter where you look. There's always going to be some kind of activation process, which involves ringing blood bank or pathology and letting them know. And you want to do that early because they've got to start defrosting and preparing products, and that takes time. All of our massive hemorrhage protocols incorporate the administration of tranexamic acid because we've got pretty good evidence from adult data that suggests that helps in terms of preventing clot breakdown. So we administer that as a bolus first and then usually a second infusion over 6 to 8 hours. The dose of tranexamic acid should be in your algorithm, but it's actually easy to remember because it's just the same dose as paracetamol, which when you're working in pediatrics is one of your most prescribed drugs. So it's 15 milligrams per kilo for both doses. Then we're treating a shocked patient. So if we don't have blood immediately available, we're going to resuscitate with saline until we get some blood. And that's usually from our own departments. Or we might have to order it from blood bank. Then, as soon as we've got blood available, we're going to want to make the switch to resuscitating with red blood cells for volume. So you're going to think of red blood cells in a massive hemorrhage protocol as your treatment for shock. Yeah. So you're going to be giving that as required to mitigate, treat, or resuscitate shock, either until the patient stabilizes or until you get them to definitive care. The other thing that you're going to be doing, though, is administering blood products. And that's because we want to help clotting as well as treat shock. And so one of the side effects of trauma for a number of reasons is that you can become coagulopathic and your blood can become not very good at clotting. So we're going to give blood products to help it clot, and we're going to give red cells for volume to treat the shock. We're going to do some kind of tests, depending on what type of algorithm you've got. There's going to be different tests that you will do to see how your blood is clotting. And then you're going to respond to those tests to try and keep the patient stable while you either get them to definitive surgical care or stabilize them enough that you can step down and continue monitoring them in a HTU type environment. Critical to all MHPs and a frustration for blood banks everywhere is that you have to remember to deactivate your protocol. It's often something that we forget because we become so task focused and we're kind of relieved when the patient's all better and we're like, great, okay, time to go have a snack. But we need to make sure that we've grabbed all the products that haven't been used, got them back to the lab so that some of them can be saved, hopefully, if we get them in time. And we need to be able to let blood bank know so that they switch off all of that defrosting they're doing and blood product preparation so that they can stand down as well. And that's basically all a massive hemorrhage protocol is. It's not really that complicated, at least in theory. When we're thinking about treating shock, as I mentioned, we're going to be giving volume, to prevent hypotension or treat hypotension. And basically, there's only two ways we're going to do that in our resuscitation. So it's either going to be with a crystalloid fluid like saline, and then as soon as possible, we're going to try and switch to whole blood, to red cells, sorry. The reason for that is that we do have pretty good examples from research in adult military in particular that recovery is better with resuscitation with red cells rather than with crystalloid. And the idea essentially being we're giving, replacing all of the products rather than just treating the hypotension itself. There is theory that, if you're giving excessive volumes of saline, then you're kind of diluting the blood and decreasing its chance to clot. So that's why we resuscitate with red cells. That's our standard dose. It's the same as you would be if you were treating shock in any kind of other pediatric patient. Key being feeling comfortable continuing to give it if they remain shocked. So that's treating shock, but we've also got to support blood clotting or coagulation. And so there's actually quite a number of different products that we need to administer during a massive hemorrhage protocol to support the body's ability to make a clot and then stop it from breaking down. And that's our key goal here, right? We want to prevent that happening. So these are the products that you'd usually give in a massive hemorrhage protocol. TXA or tranexamic acid, as I mentioned, is to prevent clot breakdown. And it's 15 milligrams per kilo is the first dose. Then we've got fresh frozen plasma. And that is a dose of 10 to 20 mils per kilo, depending on where you work. But it contains clotting factors that are needed for the chemical reactions that form a clot. We've got platelets, so that's 10 mils per kilo, and they obviously contain the platelets that actually form the clot, so we need that, don't we? And then we've got cryoprecipitate or fibrinogen. So in either of those products, there is fibrinogen, and within the clotting cascade, fibrinogen gets turned into fibrin, and that's essentially the glue that clumps platelets together to form the clot, and that can easily go low. We're going to potentially need to give calcium because we want to maintain normocalcemia for a number of reasons. Calcium stabilizes fibrin, and it's used in multiple steps within the clotting cascade. And for a variety of reasons, our calcium likes to go low in trauma during transfusion as well. So we've actually got two options for administering calcium in an MHP. We've got calcium chloride and calcium gluconate. So calcium chloride can only be given if you've got a central line, and it's thought to be a superior product. So I don't fully understand it, but the sort of density or the absorption of the calcium that's in there is thought to be more optimal, and it's smaller volume. So it's 0.2 milliliters per kilo of 10% solution. What I would say, though, is the reality is for most of us in an emergency sort of non-ICU setting, we're probably more likely to at least have started with a peripheral IV. And so usually we're actually going to be giving calcium gluconate at 0.5 milliliters per kilo of the 10% solution. And there ain't nothing wrong with that. These are all very theoretical benefits between the two choices. The reason that we're giving those products, the reason that we're going to need to do a number of other things during this resuscitation is that we are really trying to avoid the diamond of death. So the diamond of death is this idea that there are four key components that can happen when your body is experiencing traumatic injury and bleeding a lot and being resuscitated with the products that we give you. And all of those things can start causing us cascade that makes the blood actually worse at clotting, that increases the patient's chance of having severe morbidity or mortality, and it can become a bit of a relentless cycle if we're not watching it. So the four principles are: we want to avoid hypothermia. We want to try and treat or manage or optimize acidosis. We want to avoid coagulopathy by giving blood products. And we want to avoid hypocalcemia by keeping the calcium above 1. So with hypothermia, we're going to do things like warming the fluids. We're going to keep the patient covered as much as we can after we've done a thorough assessment. Sometimes we'll even warm the room. We might use a bear hugger. When it comes to acidosis, we don't treat the acidosis with bicarb, but what we try and do is help the body clear that acid itself by helping oxygenate the patient and perfusing them well. So that the body is not producing as much acidemia in the process, and we're also helping perfuse the kidneys and helping it clear it. We're going to prevent coagulopathy, as I've gone through in the previous slide, and then we're going to treat that hypocalcemia. And having hypocalcemia is an independent risk factor for increased morbidity as well. So we want to really try and be aggressive at keeping that within the normal range. Part of the reason that acidosis is such a challenge, if you look at this blood gas result, this is a blood gas from a bag of red cells. So we are putting this actively in the patient. And I got to say, when you look at that, it's a little bit scary to think about what we're actually pumping in. So, we are still primarily trying to oxygenate and perfuse the body. This is just something we have to accept. But it's a useful point of reflection just to realize that some of the products we're actually giving can be contributing to the problem. When it comes to massive hemorrhage protocols, one thing you will likely have heard of is that there's kind of two different types. We've got ROTEM or TEG guided ones, and then we've got sort of recipe or standard ones. And that can be really confusing, particularly for people who don't work in a trauma setting where they're exposed to that frequently. So we're going to spend a few slides trying to break down what the difference is, how they're different, but also more importantly, how they're actually very, very similar, because sometimes that mystery can create more damage than is actually good. So the take-home message from this slide is really that there are two ways to bake a transfusion. Yeah. So traditionally, we have come from a standardized methodology, which is essentially a bunch of scientists sit down and go, what do we reckon is the key components of people's blood? And let's make that up in a recipe so that if you give the whole recipe, you should have a reasonably good fit with what should normally be in your bloodstream. So that's a standard MHP algorithm. Usually has packed cells, platelets, and FFP. And so standardized algorithms are just doing that repeatedly, checking that your coags and stuff are normalizing or are stable and treating as needed. But the other option that we have is more of a taste test, like a bit like a master chef who just tastes their ingredients as we go and adapts things and chooses just the right sauce for their cooking. So in a ROTEM or a TEG, what happens is we're giving still our red blood cells to give volume and treat the shock. We just keep doing that. But when it comes to our products, we're doing some fancy tests called ROTEM or TEG, which have to be physically run to either an ICU or a theater setting or wherever the machines are in your hospital. And they essentially give you a live update of that blood's ability to clot. And by interpreting the results that those machines give us, we can choose which products to give more selectively. And the theory being you're giving better care because you're titrating the needs to that particular patient, and hopefully you're wasting less product. The reality, though, is that we don't have a huge amount of evidence to support a clear benefit. It does introduce a lot of human factors challenges. So we'll just explore that a little bit more. At the end of the day, there's more that is similar about ROTEM or TEG and standard than is different. In both of these protocols, you're still giving tranexamic acid. You're still resuscitating with saline or O-neg blood until you've got blood. You're then giving red cells for volume to treat shock, and you're giving blood products to help clotting. And then you're going to respond to tests. The difference, though, as you can see, is that in the standard algorithm, what we've got is pack 1 and pack 2, which are pre-formed, and they come and we just give all of them in sequence. Yeah? So we're not having to do as much interpretation. Whereas when it comes to in the ROTEM one, we've got red cells coming independently, and then we're going to keep doing that ROTEM test, sending it to the lab. Hopefully it'll come up in like a live update app, and we'll interpret that in real time and then start giving products according to our ROTEM algorithm. The principle is still the same. You're still giving red cells, you're still giving products. It's not that different when it comes to the concept, at least. Just to give you an example, if you've never seen a ROTEM result or interpretation guide, this is a component of our Metro North Pediatric ROTEM interpretation guide. And the key thing here is you don't have to be a hematologist to do this. The idea is if you have a good enough algorithm that's nice and clear, you should be able to just read it and do what it says. So even though you get some pretty pictures like you can see on the left, which represent how the blood is coagulopathic at present, and the shape of those lines is going to give you information on what type of product you need to use. But the reality is you don't need that. The machine spits out some numbers at you, and then you can just literally follow the recipe. So for this one, if the FibTem CT is more than 300 seconds and the XTem A5 is less than or equal to 35 millimeters, then you're going to give tranexamic acid and cryoprecipitate or FibCog. Yeah. And then once you've given those products, you're going to repeat the ROTEM 10 minutes after that, and then you're going to keep testing and responding to the results as needed. So that's kind of the basic concept. And this lecture isn't designed to skill you up in ROTEM or TEG interpretation, just to give you a little taste test of what that looks like. I think it is important, though, that we think about some of the finer points of ROTEM and TEG. And when you are doing those resuscitations with those algorithms, there's actually a few things that can easily make us trip up. So one of them is you need to have familiarity on where the ROTEM or the TEG machine is in your hospital, because it usually isn't actually based in emergency. It's often somewhere else like pathology, ICU, theatre. The ROTEM itself actually takes 30 minutes. And so what that means is if you send someone up and you're not getting a live update app and you're waiting for a printed out result, they will be gone for 30 minutes waiting for that to be printed out, and you will have no data mid-resuscitation to act on. So you need to know how your hospital sends that information. Otherwise, you could be waiting for a long time because the final steps in ROTEM and TEG actually test clot degradation. So they will always take 30 minutes no matter what. You've got to think about who's going to interpret this test because it takes either good knowledge or a very well-designed, easy-to-read algorithm. And so you want to have a look at that first if you're making the decision as a medical team leader. Know what your algorithm looks like. Make sure you're confident interpreting it, or just make the decision to use a standard algorithm instead. So one of the key points that I hope you take away from this lecture is that the idea of a massive hemorrhage protocol is simple. It shouldn't be confusing or overwhelming. But the execution of it is actually really complex. So there are a lot of moving parts. In addition to our usual resuscitation roles, we need to adapt our team structure to match the needs of an MHP. So a dedicated blood bank liaison doctor can be really helpful at keeping a phone line open with blood bank. So in our hospital, we actually keep that line going as often as we can so that the teams can continue to communicate with each other throughout the resuscitation. You don't have to do that, but we find it very helpful. You can see on this diagram that actually there's a bunch of parts and components and skills that we don't normally use in our traditional structures. So if you think about we've got our usual structure like airway, circulation, procedures, drugs, team lead, and scribe, and that's pretty familiar, right? But we've also got some new stuff, right? So we've got blood bank liaison, runners, transfusion, pathology signing, escalation and transfer. And those things we do less, and so we can be rusty at them. We also need to think about the specifics of who are we going to match to that task because they take specific expertise. So for example, we want someone who's consistently liaising with blood bank and letting them know where you're at with your MHP. And you want them with a phone line that isn't engaged if the blood bank is trying to contact you. So often we'll see in MHPs that the resuscitation leader makes the call, leaves their number, and then is immediately engaged for the rest of the resuscitation because they're liaising with surgery, they're liaising with retrievals, and blood bank can't get through critical information when they're trying to call back. We want to think about our runners, and this is actually really interesting because runners have a specific skill. They need to intimately be aware of where everything is in the hospital, where the machines are stored, and how to get efficiently between blood bank, between theatre, and back to emergency or wherever your patient's being resuscitated. And so that will often be a wardie. But whoever it is, you need to want to make sure to check in with them, check that they know where the ROTM or the TEG needs to go if you're using it, where they need to take the rest of the pathology tubes, because that sometimes won't be the same place, and when you need them to come back. So whether they're going to wait for the result or whether they're coming straight back and getting more ROTMs to take up and you're watching via an app. We need a team dedicated to administering the blood and the blood products. And what I would say from my experience in simulation in particular is that this usually takes, particularly in pediatrics, more staff than we think it does to do this safely. There are a lot of micro skills within transfusion that take time, that require concentration, and can easily overwhelm us at a cognitive level because we don't do it super frequently at that speed. I've put in here pathology signing as one of the key tasks that we need to allocate appropriately. And what's interesting about MHPs is probably one of our biggest blocks or failure points in doing this efficiently, at least at the start of an MHP, is the pathology signing. So it frequently breaks blood banks' heart, but they frequently have to call through with a no test on the first cross-match sample that they get for a number of different reasons. And I think sometimes in a resus, we're often guilty of passing the blood we've collected to the most junior member of the team to sign. And it's actually a point of vulnerability because there are some specifics about pathology signing for cross-matched blood that we need to pay attention to. So it's very worth taking a good 20, 30-second break, checking in with the team leader, making sure that that pathology is signed correctly, particularly the first one, obviously for all of it, but particularly the first one when you're activating the whole thing to make sure that you're getting correctly cross-matched blood and not being blocked before you've even exited the station. And lastly, we want to think about escalation and transfer. And so it's important for us to highlight that massive hemorrhage protocols are not a therapeutic treatment. They're not there to fix the patient's underlying problem. They're there to keep them alive until you can get them to definitive care. Now, sometimes there will be kids who just stabilize and you can step down, but it would be very easy to just get caught up in cycles of MHP and not recognizing that actually we need to get this kid to definitive care, i.e. surgery, or to another hospital that can do that surgery. So keep that in mind and be aware who you've got around who's going to be doing that escalation, checking in with the surgical team and making sure this patient is being advocated for, and we've got plans in place for transfer wherever that is. So that's some of the human factors complexity. And now the next few slides, we're just going to go through a couple of finer points about some of the work as done when we're doing an MHP. So we need to think about when are we going to repeat the tests, and I'm really sorry, but there's not particularly clear evidence on when that should be. So check your algorithms. For some of our algorithms, we say certainly for the ROTM or TEG guided, you're going to be doing it every 10 minutes after an intervention, which makes sense because you're repeatedly taste testing, depending on working out whether what you've done has helped. When it comes to standard algorithms, it's a little bit more tricky. There's reasonable consensus that you need to be doing it at least hourly. Our protocol says between packs, so between MHP pack 1 and MHP pack 2, and then after MHP pack 2 when you're restarting at pack 1. But you want to be testing enough that you're getting information on the patient's ability to clot via their coags, understanding where their platelets are at, because you're going to want to top those up if those are getting low. And you're going to want to be monitoring, particularly to look at their lactate and their calcium to avoid hypocalcemia. So we know that you should be repeating this at least hourly. I'd guess that most blood banks also want you to be doing it more frequently, and they'll often actually use those tests for auditing purposes afterwards to sort of work out how the patient was doing mid-resuscitation. There is this idea in the literature about transfusing to target. And I guess the challenge is in a massive hemorrhage protocol, there isn't a clear target beyond patient stabilization. We don't have clear evidence for targets for hemoglobin. We've got some guidelines for platelet targets and for, considering targets for INR and fibrinogen. But the reality is this is a resuscitation space. And so we're essentially trying to do the best we can, and we're going to have to take a lot of clinical data into account. So is the patient remaining shocked? Is going to be the key assessment point because we're going to need to continue to give volume if that's the case. I'm going to need to make the call about how to get them to definitive care if this is not wrapping up. We highlighted earlier when we were talking about the diamond of death that we wanted to avoid hypothermia. And this is relatively uncommon at the severe level. I'm talking in Queensland, so we don't see heaps of this. But the reality is that trauma and being resuscitated in a trauma room where you're often stripped off, kids have high body surface area to weight ratios, and it's easy for them to become cold while we're giving them cold products. So we want to actively monitor their temperature. We want to remove any wet clothes. We want to give warm blankets or a bear hugger. We want to warm fluids that we're administering, and I'll come to that on the next slide more specifically. Some places will even have the ability to warm gases, so to give them humidified warm oxygen. And some places with an equipped trauma room will also have the ability to dial up the temperature within the room so that there's less ambient loss. Less comfortable for us, much better for the patient. One sticking point that a lot of people have when they're thinking about and running an MHP is we know that we need to warm stuff, but we're often not clear on what we should warm and what we shouldn't. So there's actually a lot of confusion in this area, and unfortunately, there's also some conflicting advice. So some products can be warmed, but many don't need to. And there's even some arguments in the literature that some products might degrade a bit with heating. So I'm arguing today that to keep things simple, just think warm your volume, so not your products. So that keeps things nice and simple. And what it does mean is you can potentially set up, if you've got 2 points of access for your patient, set up a hotline on one side where you are treating shock with saline or blood and keep that line for that. And then on the other line, if you've got 2 available, you can give your unwarmed products. So that's your platelets, your cryo, your fibrinogen, stuff like that. Yeah. And so keeping them separate means you're not having to turn on, off, disconnect the heater, etc. And it just is a nice point of clarity. So red cells are the main one that we want to warm. We may find later there's some evidence that we should be warming other stuff. And actually some protocols recommend warming FFP, for example. But we're arguing today, just keep it simple. Warm your volume, don't warm your products. And that'll just mitigate some confusion. Lastly, as I mentioned, we need to think about terminating the protocol. So this is a common failure point, but we need to make sure that we've let the blood bank know that we've packed up the blood cells that we haven't used and the other products and sent them back as swiftly as possible, because those guys are running on a timer. And if they get back home in time, they can be put in the freezer or restored so that they can be used for other patients. So we really want to do that whenever we can. And don't forget the blood bank are working incredibly hard all of this time while we're resuscitating to keep defrosting and supplying and matching products. So we need to make sure that they can step down, focus on whatever else they've got going on in their day, which I'm sure is quite a lot, and minimize wastage of donated products from other human beings. So look, that is MHPs in a nutshell. That was a long-ish talk, but I think there's a lot to think about. This is a complex task, but the components are simple. Yeah? So just to recap, in every MHP, we're going to activate it with blood bank. We're going to give tranexamic acid. We're going to give saline until blood's available. Then we're going to give red cells for volume, products for clotting, and we're going to respond to tests. We want to prevent the diamond of death through avoiding hypothermia, coagulopathy, hypocalcemia, and acidosis. And we want to get that patient to definitive care. And then once they're stable and don't need more blood products, we're going to switch off that MHP and let blood bank know. I hope you enjoyed this talk.